Hi, my name is Michael Wallace. I'm a professor of medicine at the Mayo Clinic in Florida and the current editor-in-chief of Gastrointestinal Endoscopy. Today we're interviewing Dr. Ryan Childers from the Oregon Health and Sciences University and the Portland VA Medical Center. And he's going to tell us about his recent paper in gastrointestinal endoscopy titled Practice Patterns of Sedation for Colonoscopy. Ryan, congratulations again on the manuscript. Can you give us a brief summary of the aims and main findings of the paper?
Sure. Thanks, Dr. Wallace, for having me here. So we were interested in looking at trends in sedation use in colonoscopy in the United States over a 14-year period. We used a database called the Clinical Outcomes Research Initiative, or CORI, and we looked at the years 2000 to 2013. And we wanted to see the trends of sedation use over that time period, both type and dose. We were also interested in looking at factors that might influence sedation type, say age, gender, ethnicity, procedure length, or intervention. So we analyzed roughly 1,300,000 colonoscopies, and we found that over that 14-year period, that midazolam and fentanyl were the most commonly used sedatives. Propofol has gained a foothold over the last decade or so as well, but still is behind midazolam and fentanyl. We also found that the average dose of midazolam and fentanyl was 4 milligrams of midazolam and 100 micrograms of fentanyl, and that this dose really hasn't changed much over this 14-year period. It's stayed fairly stable. Looking at some of the factors that might influence sedation, we found that when it comes to ethnicity, in general, white patients tended to receive more sedation than African American and Hispanic patients. But if you drill down and look at individual sedatives, for example, Propofol, that's not necessarily true. For example, with Propofol, we found that African American patients received more than both white and Hispanic patients. Looking at gender, there really were no major differences across the board, although women did tend to receive more benzodiazepine. Looking at age, we found that there was a decline as folks got older, they got less sedation. In general, we saw about a 7% decline by decade of age increase. And then also we talked a little bit about in our paper length of procedure, which we found to be about 21 minutes without interventions, and then presence of an intervention, which increased the time to about 23 to 24 minutes. And in our paper, we describe in detail the types of interventions and the time associated with that. But in general, the bottom line there is that more sedation was needed for interventions during a procedure like this.
Good, thank you. The major trend I think many of us have observed over the last 10 years or so has been the increasing use of Propofol for both complex and routine procedures. Although I was a bit surprised that in your study the majority were still performed with midazolam and fentanyl. I noticed even a slight sort of blip at the most recent form with a little decrease in Propofol use. Do you think that's a real change? Are we actually seeing a slight reversal of the use or a slight decline in the use of Propofol in recent years?
I would say that I'd mention that the CORI database involves data from academic, VA, and community sites, and that we know from other authors that there can be variation geographically in the U.S. as far as where Propofol is used and where it's not. So this is a sampling. It's a large sample, but it's still a sampling, and so you may find more Propofol used in certain areas of the country. We actually believe that that little blip or decline in Propofol use in our last year data probably isn't significant because the trend has been that it seems to be gradually increasing over the 13 years that precede that time point. But certainly I think with changes in the healthcare system and maybe move towards bundled and value-based payments, Propofol generally is a little bit more expensive than midazolam and fentanyl, and so we still may see trends in that direction, that is to say less Propofol, but it's hard to say, I think.
Good. I also noticed you observed these racial and ethnic differences in sedation with, at least in some parts of the study, non-whites were receiving lower doses of sedation. What do you attribute those differences?
I think there's probably many reasons for this, and I think we already know that there are discrepancies and disparities with regards to referral for colonoscopy and for ethnic minorities to actually get the colonoscopy. I think some of these disparities can be explained by biases among providers, by socioeconomic status and access issues. I think with regards to sedation, once a patient is in the endoscopy room, we could look at language barrier. I think with regards to Hispanic patients receiving less, that might be one reason. There are also cultural differences that might prevent a patient from complaining about pain. Certainly we know that the Native American population their perception and kind of approach to pain is different from the kind of the Western model. So that might explain some of these differences.
Good. And were you able to adjust for weight here? Obviously, a heavier patient might require higher doses to receive the same level of sedation.
Yeah, we were not able to look at weight, and the core database has a lot of great variables and data, but this was not an input variable that we were able to analyze in this study.
Yeah, in my practice over the last 10 years, we still largely use midazolam and fentanyl in our screening outpatient ambulatory surgical unit. But there certainly seems to be this, and in that practice, we seem to observe higher and higher doses of even fentanyl and midazolam. Were you able to see that in the trends in your study?
Yeah, so we didn't actually. We thought we would see increases in both midazolam and fentanyl use as the years went on. In fact, we did not really see a statistically significant change. In general, from year 2000 to 2013, it stayed at, again, 4 milligrams of midazolam, 100 micrograms of fentanyl. That was really kind of a very steady level across the 14 years.
I wonder, perhaps, since at least the practices that have not routinely taken up propofol, if we're shifting away the more difficult to sedate patients to propofol, so what remains getting midazolam and fentanyl are perhaps a little easier, but so maybe that's why the dose, we haven't observed that increase in dose.
Very reasonable, yeah, absolutely.
Well, Ryan, again, thank you and congratulations on this very nice study. We look forward to seeing it in gastrointestinal endoscopy very shortly.
Thank you, Dr. Wallace.
Good.